Hi, my name is Megan Beyer, and I am a registered dietitian, and I specialize in ICU nutrition research. This course is just one in a series of modules on indirect calorimetry brought to you by Channel 1, On-Demand Nutrition Education. This module is part one in a four-part series focusing on adults. Today, we look at the patient selection and testing criteria for indirect calorimetry in adults. Our objectives today include identifying key populations that will benefit from indirect calorimetry testing. We will describe the patient selection criteria for indirect calorimetry. We'll explain testing criteria, and lastly, explain the importance of indirect calorimetry validity. When we are looking at key populations, we should always assess and not guess when indirect calorimetry is available. The key populations of patients with hypermetabolic conditions include burns, major trauma, sepsis, organ failure, postoperative recovery, where metabolic rates can vary as inflammation evolves. Mechanically ventilated patients benefit due to the ability to accurately capture oxygen consumption and carbon dioxide production with a closed circuit monitoring. Additionally, patients with very low or very high BMI also benefit from predictive equations instead of under or overestimating needs in these groups. Before testing, clinicians must evaluate patient safety, comfort, and equipment compatibility. Conditions that increase physical stress include agitation, fever, or ongoing procedures, which can compromise the accuracy of each test. Additionally, mechanical issues such as circuit leaks or incompatible ventilator modes can compromise the accuracy of test. Identifying these issues early or prior to starting a test ensures that the measurement is safe, feasible, and reliable. When we are considering contraindications and precautions, there are a few things we want to consider. So certain clinical and technical conditions make indirect calorimetry inappropriate or unreliable. Contraindications include an unstable ventilator setting, FiO2 requirements above 70%, which is dependent on your indirect calorimetry machine, a PEEP above 12, or the presence of an air leak, such as a chest tube with bubbling or potentially a cuff leak. These factors disrupt the measurements of the inspired and expired gas volumes, leading to an accuracy of VO2 and VCO2 values. It's important to become accustomed to recognizing factors that alter metabolic rates or interfere with the analysis. Clinical care that may cause a red flag for doing indirect calorimetry tests includes suctioning a patient, extubating a patient, or the use of administered inhaled medications such as bronchodilators, or the use of nitric oxide, which can also distort readings. When we're considering patient selection criteria for indirect calorimetry, there are various modalities in the ICU we need to be aware of that can affect our indirect calorimetry test. For instance, all patients who are undergoing ECMO should be excluded, as this can affect the gas exchange and result in incorrect interpretations of our results. Additionally, for patients who are on a ventilator, we need to ensure that there is a completely closed circuit. So, for example, inline suctioning catheters, humidification systems, end-tidal oxygen devices, or any other brake can affect the results that are given to measure the gas flow consistently. Other gases, such as nitric oxide or anesthetic gases, should be avoided as they interfere with the readings. When suctioning a patient, or if a patient is repositioned, this should be performed about 20 minutes before measurements are completed to ensure that the patient has returned to a steady state. Additionally, sedation should remain stable, as changing the sedation again can affect our indirect calorimetry results. Now, when we are considering a steady state, The patient needs to be in a true physiological resting state. They shouldn't have eaten recently, moved significantly, such as walking, or worked with physical therapy, or experienced acute mental or physical stress. The key criteria that we want to ensure we are working to include is fasting for at least 5 hours prior to the test, resting quietly for about 20 minutes before the test, maintaining stable ventilator settings for about 1 to 2 hours prior, avoid testing while the patient is agitated, has a fever, or is undergoing any type of procedure, and ensure there is a stable body temperature throughout. During a test, a steady state is defined by a stable VO2 and VCO2 with minimal variability. Most protocols require less than a 10% variation across the time points of the test. And meeting these criteria ensures the results reflect true resting metabolism and aren't dependent on the patient's physiological changes. Now, when we are applying our indirect calorimetry results to clinical practice, the results should be valid and integrated into our nutrition care process to guide individualized prescriptions that align with caloric delivery. Baseline testing should occur early in the ICU stay once the patient is stable, typically by about day 2 or 3. Sequential testing is recommended when the patient experiences clinical changes. For instance, this may include an infection, a patient being extubated, initiation of CRRT, or changes in sedation, because all of these factors will affect their metabolic rate. Additionally, during a prolonged ICU stay, repeating indirect calorimetry every 3 days helps us track metabolic shifts during the transition from a hypermetabolic phase to a recovery phase. Additionally, after ICU discharge or to the floor, measurements of indirect calorimetry should be targeted for about every 7 days. As I mentioned previously, we want to ensure our variability of the test is less than 10% if all the physiological conditions are stable. And it is important to record each of those physiological measurements, for instance, a fever or increased or decreased sedation, so you're able to cross-compare from one indirect calorimetry test to the next. Now, as we focus on calibration and maintenance, this is extremely important to ensure that our machine is running properly. So indirect calorimetry requires this calibration and maintenance on all its components, including the flow meters, the gas analyzers, which should be calibrated before each test to ensure that there is accuracy of both the volume and gas sampling. Additionally, the calibration syringe does require to undergo annual manufacturer calibration to confirm appropriate volume precision. Routine maintenance includes replacement of the pneumatic cartridge, oxygen sensor, and CO2 scrubber to ensure there is reliability of the indirect calorimetry tests. It is recommended that trained technicians are performing these tasks, and it may be helpful to use a reminder system or a centralized tracking system such as a spreadsheet or Outlook invites to ensure that you are having compliance with these timelines. By optimizing patient selection, test performance conditions, and equipment maintenance, indirect calorimetry becomes a highly reliable tool for delivering precise, individualized nutrition through the continuum of critical illness. I would invite you to watch the other videos on indirect calorimetry on Channel 1 series to learn more from my esteemed colleagues. Have a great day. Thank you.